Venom from the Brazilian pit viper triggers a sudden, extreme drop in blood pressure, leading to collapse, unconsciousness, and even death. This might not seem like the best place to start when we're designing a life-saving medicine, but that didn't stop a team of scientists in the mid-20th century who thought this blood pressure lowering effect could be harnessed to reduce the risk of cardiovascular disease. Their research led to the development of captopril, the first of the angiotensin converting enzyme inhibitors. This class of medicines, called ACE inhibitors for short, can be identified by the pril on the end of the name. And they started to gather a lot of interest as evidence started to show benefits not just for blood pressure, but for kidney health and heart health. And we now have lots of options available in this class. This can make things a little bit tricky when we're prescribing them, as there's a lot of data knocking around. As with anything, we start off with the BNF and the SPC, as they both have excellent guidance on this. But there's 4 things that I wish I'd known before I started prescribing them for patients. And so, let's get to it. The first of these is unusually for a blood pressure lowering medicine. ACE inhibitors don't actually lower the blood pressure that much. They work really well in combination with calcium channel blockers or thiazide diuretics. So what we should do is we should start at a low dose, say 2.5 milligrams or 1.25, and add in one of these drugs rather than titrating to the max dose. Second, it's really important that we arrange a U&E check and a blood pressure check after starting and after every dose increase. Whilst this would pick up a decline in kidney function, it's not actually that common for ACE inhibitors to cause this on their own. It's usually other factors contributing to it alongside the ACE inhibitor. To me, the most important reason for this is actually monitoring the potassium levels, as these can rise quite high with ACE inhibitors, and to me that's probably the most common reason that we hit a limit of how high we can titrate it, or we have to choose another blood pressure treatment. I would usually arrange these 2 to 4 weeks after starting or increasing, but your surgery might be different. Third, ACE inhibitors cause the buildup of a chemical called bradykinin. Bradykinin irritates the cough reflex, causing the most commonly recognized side effect, a tickly cough. What a lot of people don't know though is that bradykinin has effects elsewhere in the body, so it can irritate the lining of the nose, causing a rhinitis picture or a postnasal drip. And these are often attributed to other causes, whereas we could often resolve all of these issues by swapping to a very similar class of medicines called an ARB or angiotensin receptor blocker, which doesn't lead to the buildup of bradykinin, so that doesn't cause all these symptoms. So just have a look out for that. Finally, ACE inhibitors do have a chance of causing a very severe life-threatening reaction called angioedema. Remember that although it's rare, it does still happen to some people, and the risk of angioedema is significantly higher in Black patients. A tragic example of this affected a rapper called MF Doom, who passed away in 2020 as a result of this reaction. So I would recommend using an ARB first line for Black patients. Please remember that ARBs still carry this risk, so we should counsel patients on what to do if the symptoms do present. So putting all this into practice, what I would recommend you all do is to pick an ACE inhibitor, become familiar with it, and then stick with that. I would say the 2 to choose between would be ramipril or lisinopril, as these are the most cost-effective ones at the time of filming this video. I personally choose ramipril because that's what our local cardiologists prefer, and I find it doesn't have a ceiling of blood pressure lowering effect that we see with lisinopril when we get to 20 milligrams. We should start small with the dose. I would say 2.5 for ramipril, 10 milligrams for lisinopril, and half that if we're using it in elderly or frail patients. And that should become the increment that you increase by when you do ultimately titrate upwards. So there you have it. You can now start ACE inhibitors confidently for your patients. Tune in for the next video where I'll be covering ARBs in more detail, as this class of medicines has some key advantages that ACE inhibitors don't offer your patients. So it's really important we become familiar with these so we can use them to our advantage. See you there.